The second part of the meeting is dedicated to high-flow nasal therapy as a home therapy. Professor Annalisa Carlucci will defend that high-flow nasal therapy should be prescribed for patients at home.
Thank you very much, Manel, and I would thank Ebreas for this kind invitation. So I would start, this is a pro-concession, I would just gain some points by starting, and let me give you some key of interpretation of what me and Professor Gonzalez will show you. Actually, the country where we come from, the sunny Italy and the gray France, even if today is a very beautiful day, but Paris is different. And sense of beauty, very different. And even I think le plaisir de la vie, needings, I think are very different. So this is a key to interpret our talk. So these are actually the topic that I will treat about the use of high-flow therapy at home to treat dyspnea, to treat chronic hypercapnia, and to prevent exacerbation. So what we know about the ability of high-flow to treat dyspnea? Dyspnea actually is defined by the official document from IPS. The demand for ventilation exceeds the capacity to provide heat. And this becomes increasingly unpleasant and distressing. So what we really know, and I will not spend many words about this, are the physiological effects of high flow, more accurate and stable oxygen delivery when we need it, nasopharyngeal dead space clearance, reducing respiratory resistances, positive expiratory pressure, that means more increasing of expiratory resistances, all is able to reduce the work of breathing. And actually, the question is this true? This is a fantasy or reality? This is a physiological study that was performed by positioning a gastric and esophageal balloon in patient and comparing for randomized situation standard oxygen, high flow at 20 liters per minute, high flow at 30 liters per minute, and non-invasive ventilation. And what they found, according to the measure made by the balloon, was in terms of PTPDI per minute, that is actually the cost of the diaphragm, oxygen cost of the diaphragm, so the work of breathing, is significantly reduced either with the high flow 20 and 30 and better with an IV, but significantly reduced by using high flow. And we know that this is true not only during in awake patient, but also during sleep. And this study was performed during sleep, either in control group, healthy subject, and also in COPD patient. And as you can see, in both groups, minute ventilation were reduced by high flow, and high flow was compared in this case with only oxygen, 2 liters per minute. So both were able to reduce minute ventilation, both were able to reduce tidal volume. But what is interesting, there was a little reduction of work of breathing with oxygen, but significantly more important reduction by using high flow. And another point is that with oxygen we had an increase of transcutaneous PCO2, while during high flow there was a decrease of PCO2. And this is true also during exercise. Dyspnea is in COPD patient, above all exertional dyspnea. And as you can see in this paper published by Serena Cirio, actually dyspnea was significantly reduced by using high flow at ISO time compared to the standard group. And this allowed to increase actually the endurance time. So I think that now Jesus is saying, yes, but Annalisa, this physiological effect does not mean changing the outcomes. But this is not true, because we have some clinical study who show that enrolling COPD, hypoxemic COPD, and in this study actually 200 patients were enrolled to be treated either with high flow or in standard therapy. As you can see, from the first month of therapy, there was an increase in the perception, a decrease of perception of dyspnea, and improvement in quality of life. And even there was a decrease of ability to exercise in the standard group, while there was a stability in the 60-minute walking test in the patient using high flow. And coming again to the exercise, this was a randomized Italian multicentric study where actually high flow was added to rehabilitation compared to normal oxygen, and actually the primary outcome was not reached. But as you can see here, there was a significant improvement in the 60-minute walking test compared to the standard therapy. So there was an adding value to the rehabilitation in terms to walking distance. And as you can see here, we had a more increased percentage of patients who reached a clinical, significantly clinical increase of walking distance in the group treated with high flow. So perhaps for Jesus not enough relevant. I think yes, it's relevant, because we know that the activity and the exercise is very important, and actually it may impact on the mortality of COPD patient. And we know also that dyspnea and exercise in terms of 60-minute walking test, so the walking distance, may impact the mortality, either if used in the body index or in the new one, the FODEP index. So I think really very important. And last but not least, actually our aim is also to try to alleviate suffering as a high priority. And this may be applied also in the palliative care. Because actually dyspnea is a very important outcome in some end-of-life respiratory failure. And in this paper, even retrospective paper, for example, it was applied in interstitial lung diseases. As you can see, respiratory rate and dyspnea score was significantly reduced only by high flow compared to non-invasive ventilation. And this was also an experience coming from France, because as you can see, this group from Maxime Patou actually applied the use of high flow therapy at home, actually to allow patients to go home. And as you can see, the majority of them were patients with interstitial lung disease, pulmonary hypertension, lung cancer. And even these patients have a poor survival. Actually, they had the possibility to come back. And they showed that perhaps money were saved. Another important topic is the possibility to use this, to apply this tool also in hypercapnic respiratory failure. And we know that hypercapnia is very important as main determinant of mortality in COPD patient. And we also know that the last guidelines from European Respiratory Society actually suggest to use non-invasive ventilation in hypercapnic patient, but this is a conditional recommendation with the low certainty evidence. And we already know from this interesting paper that actually there are some patients that are well responder to non-invasive ventilation, but there are a lot of patients, as you can see here, who can worse after application of non-invasive ventilation. And some of them are patients who are able to improve PCO2 by applying non-invasive ventilation. And either we know that non-invasive ventilation is not the only possibility that we have to treat this patient, because actually we are not able with non-invasive ventilation to reach a complete success in all the outcome that we have. And if we try to reason about the physiological cause of hypercapnia, actually here you can see that the ventilatory reserve, that is the balance that we said before between ventilatory demand and ventilatory capacity, is one of the most important determinant of hypercapnia. And what is the determinant of this imbalance between high ventilatory demand and low ventilatory capacity is above all hypoxemia and ventilation of dead space. And we know that high flow is able to reduce this ventilation of dead space. In this physiological study, as you can see, actually the application of high flow is able to reduce minute ventilation, but this reduction is mainly due to a reduction of dead space ventilation. And this is proportional to the physiological dead space that the patient has. So what are the clinical studies supporting this physiological data? The last study that I showed, physiological study from Lara Pisani that I showed you, who showed a significantly decrease of worker breathing, also showed a significant decrease of PCO2. But also in this more longer and not acute physiological study, comparison of non-invasive ventilation with high flow showed the same similar reduction of PCO2 after 6 weeks. This study from Nagata actually enrolled hypercapnic patients and followed them for 1 year. The primary outcome was the quality of life and the PCO2. And as you can see, actually, high flow was able to significantly improve the quality of life of the patient and significantly improve PCO2 either during the day and nocturnal transcutaneous. And actually, this is a preprint, not published data from the new study from Nagata, where actually again they enrolled hypercapnic patient to be treated with high flow and long-term oxygen, 100 patients. The primary outcome was actually the rate of exacerbation, but they found also a significantly reduction of mortality. Last but not least is the ability to prevent exacerbation, so the utility to use it in patients that are defined frequent exacerbators. We know that actually the environment and the temperature or airway are very important for the mechanism of activity and the activity and the velocity of ciliary beats. And this is quickly reduced when the temperature reaches 34 or 30 degrees. And actually, we don't have a lot of study, but this first study, published in 2008, tried to actually understand if there is the ability of high flow to improve the mucociliary clearance. And they found that, as you can see here, before the treatment and after a treatment with high flow, there was a significant improvement of mucociliary clearance. We have a clinical study published in 2020 where actually patient either COPD or bronchiectasis 100 were enrolled to be treated with a standard therapy or high flow, 20-25 liters per minute. And actually what they found was that patient had a significantly fewer exacerbation day, increased time to first exacerbation, and reduced exacerbation frequency. And actually they tried to make a new analysis only in the bronchiectasis patient, and this was published last year, and they found that even in bronchiectasis, the rate and the number of exacerbation per year was significantly reduced by 31%, and even the quality of life significantly improved. But also in the study that I before showed you, the secondary outcome was actually the exacerbation rate, and after 1 year, as you can see, the exacerbation rate was significantly reduced. There is one trial in Italy, a randomized controlled trial, that we will see the results. They are enrolling the number of the patients that will be enrolled will be 130. What I would say to conclude this my talk is that perhaps we have to consider that we don't have one particular treatment able to improve all these outcomes that I showed you, and perhaps a multidimensional treatment could be very interesting for this patient. High flow has strong backgrounds and several evidences of physiological effect and improvement of clinical outcomes. However, I know the technologies now are the more and more easy to use, so this is in favor of use of it. However, we need to perhaps answer to some questions, and this is what perhaps the crow Jesus will say. We don't have many answers to question about how many hours a day we have to use it to reach the outcome, which is the minimal flow we suggest to use, which is the better phenotype of patient to treat, which is the best outcome, and how to evaluate the clinical improvement. So many limits, I know. I could suggest that waiting for stronger evidence, high flow should be used at home in selected patients. I think it's very important to start from the physiological knowledge and to have clear your objective and make a strict follow-up. Thank you very much.
Thank you very much, Annalisa. I'd like to invite Jesus Gonzalez to come and argue the con that a high-flow nasal therapy should not be prescribed for home care.
Thank you. Thank you very much for this invitation. And Annalisa sent me her pictures to work together, but without the picture of myself in. Thank you. Thank you. For next time, I will change my way to make the. So you have spent 3 days in the JIVD, every day with a session about high flow therapy, with a positive result. The same studies every day with a physiological result of this fantastic tool. And a guy at the end of the Congress is arriving and has the job to say to you that there is no use to use it at home. Well, it's difficult, and it's what I am trying to do now. I am going to show you with a different way to see these studies and this treatment, why, for me, it's not time to use this treatment at home. Here my conflict of interest. I don't have any conflict of interest about high flow therapy. And what is important to say, it's I'm not going to lie to you because currently I have no patient with high flow therapy at home personally. So I'm not going lying to you. I'm going to explain to you why, for me, I am not convinced that it works for the moment at home. Because I can't say it's a good treatment, because it is a good treatment. It's just an incredible treatment. We have used it a lot, like we see in these publications, especially in the last 2 years. This treatment has saved a lot of people in acute, and it's what you see here. The majority of the publications are about the acute use of this treatment, and if you look at the publications about home, you see that we have very few publications. That's why I'm going to show you the same studies, but with a new red line to read these articles, and I hope that I will give you a new red line to read the next publications we will have about this treatment at home. And the red line is going to be around physiology, because I am from the Paris School of Respiratory Physiology of Thomas Imilovsky, and for me, physiology is always the best way to understand why your treatment works, what doesn't work, or to understand the study. I would like to remind you that what are the difference between high flow oxygen therapy and the other treatments we have currently. The difference between high flow therapy and standard oxygen, it's the flow, the high flow. We sent with high flow therapy a very important flow of air or of oxygen, and we had temperature, we warm air and humidification. With classical oxygen, we just send a flow of oxygen, only oxygen. The flow of air, the patient take it himself, and normally, it's what we do in France, we do not add humidification or warm air. So that's the first difference. The most important thing to understand is the difference between a CPAP and a high flow therapy, because both send a flow, a very high flow, and both produce a pressure. That's why we can have a CPAP effect with a high flow therapy, and we have flow with a CPAP because the pressure is produced with the flow. And you see here that in fact it's exactly the same device, but the problem is when you have leaks. When you have leaks as a CPAP, as a target, when you have leaks or any problem, as the CPAP, the target is to maintain a expiratory pressure, constant pressure, the device is going to increase the flow. With high flow therapy, as the target is to maintain a flow, a high flow, the pressure is going to decrease if you have leaks because the flow is going to be constant. You see here on a bench, I produce with my colleagues a leak with the two devices, and you see exactly what is happening. And what is interesting is with the high flow therapy, you see that there is a small increase in the flow, but quite constant. So don't forget that it's around the same devices, oxygen, CPAP, high flow oxygen therapy. It's not very different. And the red line I want to give you to read again, sorry for that, again and again and again during these 3 days, the same studies. I want you to look at the methodology of these studies, and especially the settings of the device. The setting of a device is going to explain everything, because sometimes you are going to have one type of effect the warm air, the humidification, and another time you are going to have another effect, the effect of a flow. Let's start with each of one. The warm effect, you have seen many times this study. It was, first of all, it was an animal study, and it's not high flow. It's not high flow therapy. The flow was set at 4 liters per minute. 4 liters. It's just warm air. And warm air, it's true, improve mucociliary transport, okay. But is it going to be the same if you had a very high flow of air to this bronchus? Not sure, not sure. So be careful. So be careful. Here, in this physiological study, we will be trying to prove that high flow therapy with warm air will be interesting for mucosal secretions. It was just warm air. It was not high flow therapy. In this study, if we had the high flow and we put that in a human, high flow, here, look at the flow, it was around 60 liters per minute without oxygen but with warm air. It was not very well tolerated. And it's my problem in my rehab center when I saw the studies published by our Italian colleagues, Vitaka and colleagues. I immediately tried that in my patients, but they do not tolerate it. Especially, they do not tolerate the flow, especially when they open the mouth, and they do not tolerate the very warm air. In my unit, in my rehab center, we are not good enough, but we don't use that because patients, exactly like in this study, they do not tolerate cycling when you send a very high flow and warm air in the nose. Humidification. Okay, you have seen also this study showing that 1 year later, these track patients had less secretions, but let's go back to the settings. Here, it's a between. It's not very high flow, like we have used it in the COVID crisis in the ward of pneumology and in an intensive care. It's a middle flow, 30 liters per minute. Warm, but without oxygen. So it's not high flow, it's medium flow, and it's oxygen. So I am coming to my final conclusion. We are not talking about the same device, the same settings, the same solution. And try to have this red line in the future when you read the papers about this therapy, because it's not the same. Let's go back to another physiological study. Annalisa showed it, showing that it improves the comfort when you have humidification. Again, the settings were not showed in all the slides you have seen. It was not high flow. It was just humidified and warm air pushed to the patient, and yes, the patient likes it better than not humidificate and warm, but it's not high flow. So all these physiological studies you have seen during these 3 days, in fact, they were talking about different settings, different devices. In fact, it's the same device, but different physiology and different philosophy behind. And let's go to the effect on COPD patients, and this very interesting effect that is that you decrease the work of breathing, and I am completely convinced that it's due to a PEP effect. In this study, when they look at the high flow without oxygen, and it was not clear if it was warm or with high temperature, it was not in the methodology, you see that you produce expiratory pressure to your patients, and we know that in COPD patients it decreased the work of breathing, CPAP decreased the work of breathing in COPD patients, and you lose this effect if you open the mouth, like the bench I showed you before, because probably you lose the CPAP effect. And this study also that you have seen during these 3 days with a beautiful picture showing that you wash the CO2 in the upper airway, it's true. If you use any flow, even hyperventilation, but if you use any flow in the upper airway, you are going to wash the CO2, and you are going to decrease mechanically the PCO2 of your patients. So as you sent flow in your upper airway, it was not oxygen and it was not written, it was humidified or warm. If you send flow to the upper airway with any type of device, ventilator, CPAP, even a fan, or exercise with hyperventilation, you are going to decrease the PCO2. Yes, it's physiology, it's logical. And to finish, about the reduce of the work of breathing, first, it was not in chronic patients, it was in acute, very severe acute patients. You have seen all these studies showing that you decrease the work of breathing. It was the first step to go to the chronic use in COPD and to the paper of Lara Pisani to test it in chronic use. Yes, it was true. You reduce the work of breathing, but what was used in this study? Probably it was a CPAP. It was a CPAP effect use, because here you see that the settings were with very high flow. And let's go to the chronic and physiologic effect. And again, probably the most important study in physiology in chronic patient, this work of Lara Pisani, that she shows that you decrease work of breathing. Okay, I agree with that. For me, these studies, I am making a critic, but these studies are always right. I'm just showing you that the truth is not perhaps what is concluded, but the results are always good. And this is clear. You reduce the work of breathing, but, well, how interesting is this NIV that let a patient at 55 or PCO2? I would not say that this is an optimal treatment, and even with a non-optimal treatment, you decrease better the work of breathing. What were the settings in this study? A middle flow. A middle flow. And what is very interesting in this study is Lara Pisani, in the discussion, they make a lot of hypotheses why it works, what it seems to work in COPD, but you will see that it's only hypothesis. CPAP effect, they say no, not exactly, because it's probably that the bronchus are better, they are more open, etc., etc. But you will see in the discussion that even for the authors, and it's normal, because the physiological study that I show you at the beginning, for me, they don't explain clearly why it should work in COPD so well as it has been explained during these 3 days. In this study, first, she clearly shows that, okay, there is a small effect, far more or less than NIV, and even with non-optimal NIV. And here it was a middle settings. So my first conclusion, physiological conclusion, is that physiological studies are talking about very different treatment. Treatment with a flow effect, high flow of air, of oxygen or not, and for me it's probably a CPAP effect. Humidification effect, and it's always studies with very low flow to be tolerated and with a very humidified and warm end, and a between humidification effect and flow effect. It's a medium flow and with humidification and sometimes oxygen, sometimes not. What is very different, what we have been using during these last 2 years in our intensive cares or in the wards, it was very high flow of oxygen, of air, of humidification, of and warm air. Don't be careful. We are really talking about different things. And then if we go to the clinical studies, yes, Maxime Patou and colleagues did it at home as Annalisa and Carlucci show that with high flow and high oxygen. But if you ask him, how was it? It was easy? It was horrible, because patients had to have 2 tanks of oxygen at home. You show in the results of Annalisa that the flow of oxygen was around 20 liters per minute at home for oxygen. So you must imagine how many times you must change the tanks. And the clinical results are very positive in intensive care. They reduce mortality but it's high flow and high oxygen. They are positive for decreased secretion and exacerbation in tracheostomy patients in acute settings with high flow, not middle flow, not low flow. But let's go to the studies shown again in the days before. This one, it has been considered as a positive one. First, the result was only positive in the patient with bronchiectasis. And let's go to the settings. What was the setting the device used? The device was low flow, not oxygen. It was just low flow with humidification. So it's really the treatment in the part humidification, well tolerated, and okay, they show a decrease of exacerbation, but especially why? Because the majority of COPD patients that were in this study, they had bronchiectasis, and it's probably a bias to explain the positive result. And I would like to the most interesting result and the biggest study around that at home. It's this study of Stuttgart. Okay, they decrease dramatically the exacerbations with high flow, set as what type of a device? Humidification, 20 liters per minute, a bit, quite not oxygen, and warm air. 8 hours per day. 8 hours per day. This study has a problem. First, the patients had a lot of exacerbation before. Well, it can be. But the main problem of this study, and it's a pity because it's a very, very nice study and very stringent, is that they exclude, you see here, discontinued the study. They exclude all the patients in who the treatment of high-flow nasal therapy was not tolerated or did not work. So, of course, in a study in intentional to treat, if you exclude patients that it doesn't work, the result is going to be very positive. And just let's go to I am very embarrassed with that because I see these positive results, as shown very well by Annalisa, and I will ask her later if she uses it in a rehab center, because in mine, I am not able to use it. Really, patients don't like it. I don't understand. It's true that we use sometimes with the patient has dyspnea, we use fans, 10 euros on Amazon. You use a fan, it's a flow, and the dyspnea decrease of the patients. Perhaps it's the effect. But I was very happy to see at the end, and very recently, this meta-analysis in rehabilitation. At the end, this meta-analysis showed that globally, there is no positive result except in the improvement, that is in the study of Vitaka, improvement of walking test, but if not, globally, if you take all the studies published in rehabilitation, there is no positive result. Palliative treatment for dyspnea, probably a result, but I will conclude with that showing an interesting study. And I'm going to finish with what is very interesting also in COPD patients, the decrease of PCO2. First, yes, in the Stuttgart study, but I remind you that the patients that did not tolerate the treatment were excluded of this analysis. You decrease, it's true, you maintain no hypercapnia. In the group blue, in which it was classical oxygen, the hypercapnia increased a bit. Well, it's not a lot, but yes, I must confess, I see this result. It must be probably interesting. And we have 2 or 3, now we are going to have a third one, as recently showed. We have 2 or 3 studies showing that you decrease PCO2. But again, let's go to the settings. What are they? How here is just 20 liters per minute. Okay, middle flow. So the CPAP effect is not very clear. And if you see the results, beautiful results showing this figure where you see each trace is a patient with NIV down and high flow oxygen up, you see that the decrease of PCO2 is not very important, first. So is it useful to do that? And secondly, the most interesting thing is the middle line. The middle line is the evolution when it was a crossover. You test one treatment first and the other treatment after, and then you change. And you know that, and you see that patients change are completely different, all of them. Some patients increase PCO2 and then decrease with the other device, other patients decrease and increase. So, well, it's difficult to understand. And I would like to remind that we miss a group in this treatment. This one is the group of sham treatment, because I remind you that Strick showed that in hypercapnic patients with COPD, after exacerbation, if you do nothing, well, just normal oxygen, if you do nothing, the PCO2 decrease by alone with doing nothing in the patient. So be careful with devices. And it's perfect. My conclusion is that high-flow nasal therapy is probably interesting at home for COPD patients to reduce exacerbations. And you have seen during this Congress that we have 2 randomized control studies that are going to start, and they are with middle flow. For hypercapnia, for dyspnea, for rehabilitation, for me, we should go on with NIV. There is no proof enough, and I don't believe it. And for hypoxemic patients with hypoxemic failure, I don't think so, because you need too much oxygen. We see that the conclusion is not very clear, because for me, the red line that must be followed is that we are not talking about one device, one treatment. It's 3 treatments. First one, high flow, high oxygen therapy for acute. It must be in intensive care of very severe hypoxemic patients. Second type of device, a middle flow with middle hypoxemia. And it's here where I put all the devices that you see here. Even if they are complicated, it's useful in the wards. And the third type of device is for home. The future will be probably to see if it works with exacerbations, with very low flow, just humidification, etc. And the red box is not for home, even if Italians are always here to contradict me, because just a publication showing that even the red high flow and high oxygen can be done at home. They did it with some patients with COVID, but well, I think it's, be careful with that. My main conclusion is that we are not talking about the same device. Thank you.
Thank you. Thank you, Jesus. Your talk is really consistent with your clinical practice, because you never prescribe high flow at home.
No, never. Never, because if I would do it, it would be for decreased exacerbation. And first, there is no reimbursement in France. Secondly, for me, the devices that, again, I repeat it, are very useful in the ward, and I perfectly know how to use them. At home, they are still complicated with humidification, the water, etc., etc. So no, for the moment, I don't.
Thank you. We have several questions. No.
Okay. This is me reading without my glasses. Dear Annalisa and Jesus, thank you very much for your presentations on the pro-con on high flow. In terms of physiology, for which patient phenotypes would you consider pressure to be more important than flow and humidification?
With the physiology of COPD, patients with overinflation, with emphysema, high dyspnea, it would be more interesting to use the flow effect and the CPAP effect, and with profile of exacerbation, though more the humidification and warm effect settings. But it's just my idea, because these phenotypes were not separate in the studies. Annalisa?
Actually, I'm convinced that perhaps I prefer the effect of modification of respiratory pattern and efficiency of the ventilation that I think that we can obtain even with low flow, 25, 30, because actually the ventilation, the flow generated by a stable patient is not so high. I don't think that is useful for hyperinflation. But I think that the improvement in ventilatory efficiency by reducing ventilation of dead space is the most important effect.
And Gerhard has a second question that he'd like us to ask on his behalf. Isn't high-intensity NIV, with big differences between EPAP and IPAP, sending a high flow during inspiration?
Yeah.
Yes.
Yeah. Yes.
Yes.
The answer is
Yes, of course, it's a very high flow, and what we could recommend, and we work on that, and I try to convince the manufacturers. I've been trying to convince the manufacturers for this. Try to improve your humidificators. It's very important to improve the humidificators because when you have high pressure and high flows, the problem is the air pass very fast on the humidificator, and the air is not humidified and badly tolerated. I think that we should improve a lot the humidificators of the ventilators. It's one of the key points.
And perhaps one difference, I think that Manel, that is the physiologist, may...
I'm the chairman.
may consider is the output of the ventilator. One thinks is to give a flow, a very high flow, and one thinks is to set the pressure. Perhaps it may be changeable and according to the respiratory effort of the patient, and this cannot change.
Yes, this is an important issue because perhaps the question is not the flow, but how this flow is delivered.
Yeah.
Flow over time. There are differences between ventilators about how flow is delivered, and probably the needings for humidification are related to this point. Okay, we have a question from Spain, from Navarra, from Cristina Siorba. When you mean high flow therapy, sorry, I don't have my glasses, which is the level of flow you are using? Because according, I suppose, to the definition of the high flow oxygen therapy is when it's above the peak inspiratory flow of the patient. How do you set?
I usually, in the chronic patient, use around 30 on average. That may be also 35 if we had a good tolerance and an improvement of symptoms, yes. Different is the exercise. The exercise is like an acute patient. So there we try to use the highest flow that we are able to use.
Yes, exactly. And what is very important to see is that the flows of the patients are going to change a lot between the situation. What is explained by this slide, in acute setting, the patient is going to have a very high flow. We saw that with the COVID patients. During effort and exercise, very high flow. At rest, and to be tolerated, and during 8 hours for sleeping, probably less flow. And yes, 20, 30 for quiet situation, and more than 30, around 40 and 60 for exercise or acute problem. But then the problem of tolerance.
Can I ask you something? Can you hear me?
Yes.
Stefano.
Yeah, I had a question for Annalisa and a question for Jesus. Jesus, I respectfully disagree with the fact that you described the Pisani paper as a CPAP effect. Actually, Mudel has nicely shown that CPAP is totally different compared to high flow, because while high flow increase the expiratory resistance, CPAP does not increase expiratory resistance. So the mechanism why high flow change the breathing factor could not be related to the CPAP effect first. And to Annalisa, I would ask you something. You show a nice study about sleep. However, it works probably in COPD during sleep, okay, but it does not apparently work in overlap syndrome. That means that if you are obese, you need to apply a real CPAP to correct the sleep deficiency rather than a high flow. So this should be very clear to the people that high flow does not correct probably sleep disturbances.
After an acute episode of PCO2, of acute exacerbation, they found a significant reduction of PCO2 in the whole group, but when they considered the group of patients with overlap, there was no significant effect. So if the patient has an overlap syndrome, surely this is not the case.
And just for me, thank you, Stefano. Yes, you are completely right. And we don't have time to come to the hypothesis why it can decrease PCO2. Everything is written in the paper of Lara Pisani in the discussion and very well explained. But it's true that I'm still not understanding exactly how you can decrease the PCO2 with these patients, except a CPAP effect. The other hypothesis, it very well described. I think they should be proven, and I hope and I'm sure that you are going to do the studies to explain perhaps better why PCO2 decreased. For the moment, I must be convinced.
We have a question from the audience. Jean-Paul.
Thank you to all of you. It's really great listening to this discussion. I have a problem with the physiology that Jesus just mentioned. The question of PCO2. If we take the definition of physiological dead space, it's actually the volume in the lungs which does not contribute to gas exchange. Okay, and so our minute ventilation is the sum of alveolar ventilation, which will determine PCO2, and dead space ventilation, which has nothing to do with PCO2, since it does not contribute to gas exchange. So how can we use this explanation, which we find in the literature, of washing the dead space as an explanation for the effect on PCO2? This, for me, does not make sense. Where am I wrong?
If you wash the dead space, the level of CO2 in your upper airway, and even if your lung will be lower.
No.
And
your arterial CO2, no, because the production of CO2 is your metabolism. So the production of CO2 is going from the blood to the airways, and if you take precisely the dead space is supposed to be non-contributive to gas exchange. It's like a lobectomy or a pneumectomy.
Perhaps it may due to reduction of work of breathing. That means I have a reduction of total ventilation because I have reduction of ventilation of dead space. So the cost of the ventilation is reduced with the same alveolar ventilation.
Yeah. That makes sense.
Yep,
Can I come in? I mean, my understanding was that you were basically flushing the CO2 out of the anatomical dead space, so that you reduce CO2 rebreathing effectively. You're replacing CO2 in the anatomical dead space with air.
In our anatomical, in the dead space, the anatomical dead space, the levels are so low that they do not contribute to the PaCO2. So even washing out...
When you're breathing out, in the exhaled gas, that may not be true, because ultimately it's all going out that way. That's how CO2 comes out of the body.
The untitled CO2 is lower than the arterial CO2.
Yep.
You see
Indeed.
that we have still physiological questions. This device.
Claudio.
I try to answer was that I think that the problem is the inspiratory CO2. That is, when we see the curve of entitled CO2, there is residual CO2 in the airway. So the airway, the dead space, is not empty of CO2 as the end of expiration. So when we breathe CO2, and this is the rebreathing, and when we wash the airway, the upper airway, we eliminate this CO2 that we inspire in each inspiration. It's my explanation, as it's like that, as I understood that.
Yes, absolutely. I remember, probably you remember also, Stefano, there was a technique in the ICU that was called tracheal gas insufflation some years ago, and probably high flow is working in the same way.
I don't know it was going to be a physiological discussion, but I'm very happy to.
It's been a really interesting end to the debate, and actually we've changed everything to a physiological discussion, and I think that that's excellent, and we can learn so much just from having slightly different ways of looking at things. I'm just going to bring it back to the question that we had, or the topic we were debating. So perhaps those of you in the audience would raise your hands if you would never, in any situation, prescribe high flow therapy at home. 1, 2. And raise your hands if there would be a situation, any situation, that you would prescribe high flow therapy at home. Okay, so some but not all. I'd like to take this opportunity to thank all of you for attending this symposium, whether it has been virtual or online. And I'd like to thank all of our speakers, Mark, Stefano, Annalisa, and Jesus, for a fantastic debate. Thank you. And my co-chair, Manel.